We also need to explain what should and what shouldn't patient do during the examination. Like patient should have to follow the instruction and shouldn't have to move much at this examination. Through explanation will increase patient compliance, improve image quality, and shorten the examination time. The following is the preparation process of cardiac MR perfusion. Before the examination, the assessment will be held by a doctor to find out the medical history and indication of the examination. After it declared safe, patient fills out informed consent. After that, we record the ECG and then an IV line is placed on the left and right hand for adenosine and contrast media. At the examination room, patient position supine, head first, and ECG placed on patient chest. Put the respiratory belt at belly or lower ribs. Place coil on chest area and BP cuff on the leg area to monitor heart rate and pressure. Cardiac MR perfusion protocol may be differ from one hospital to another, and this is a protocol that we use at Harapan Kita Hospital. It takes around 45 until 60 minutes. It also depends on the condition of the patient. As you can see on the screen, there is stress and or rest perfusion. Decision about stress or rest perfusion was made by the doctor after doing assessment before the examination. For stress perfusion, pharmacological stress agent that used in Harapan Kita Hospital is adenosine. There are several contraindications for adenosine stress cardiac MR, and is known during anamnesis. Adenosine dose was given based on patient weight. Adenosine is vasodilator and has very short half-life, so it's considered more safer than other pharmacology stress agents. We start the examination by taking 3 plain localizer sequences. And then we continue with morphology sequences by black blood. The purpose of these sequences is to assessment anatomy of the heart and mediastinum, as well as thoracic aorta and great vessel. It's done in axial, coronal, and sagittal view. With these sequences, we can also doing short scanning if there is additional indication like KISS, FUC pleura, and FC pericard. Next scene is function or scene sequences with SSFP sequences or single shot free precision with 2-chamber, 4-chamber, 3-chamber or LVOT, and then short axis. All of the scene sequences purpose is evaluation of the cardiac wall motion, ventricular volume, ventricular mass, valvular function, and movement of blood through the heart. And we can continue with edema scan. Edema scan was by T2 STIR or T2 DIR sequence. The purpose of the sequence is to look over myocardial edema from myocarditis or active inflammatory disease. We also made a mapping scan. It is T1 mapping and T2 mapping. T1 mapping was taken to look over myocardial early edema or microedema that can be seen from edema scan. T1 mapping used to find early fibrosis process. T-flow sequences is additional sequences that can be done or not depend on condition of the patient. As we can see in this patient, from the four-chamber view, we can see that this patient have a severe or moderate severe mitral regurgitation. So we do additional sequences that is key flow for pulmonary artery and for aorta. And then the perfusion scan sequences. Perfusion scan sequences was held after 3-minute adenosine through inside the body, or after the heart rate of the patient was increased 10% from the heart rate at the beginning. At the perfusion scan, we also put contrast media to the patient. After the perfusion, we insert the second contrast media, and we have to wait around 5 minutes to make these sequences. This is a loop locker sequences. Loop locker purpose is to find the optimized TI prep time for applying on LGE. The LGE sequences or delay enhancement was done. The purpose of the sequences is to detection of myocardial changes such as scar, edema, necrosis, and fibrosis. And it also can to evaluate the viability. It's done in 2-chamber, 4-chamber, 3-chamber, and short axis position. And this is the result of the delay enhancement. At the short axis, we can see that around the bull's eye, there is a white part at the LED area. Also at the vertical long axis or 2-chamber, there is a white part. And then at the horizontal long axis or the 4-chamber, we can see also the white part. It's called scars. After the examination done, the nurse will detach IV line and patient will be observed for the last time to see if there is any effect after examination. The conclusion of my presentation is poor images leads to poor diagnostic accuracy. Good images is a result from good preparation, good planning technique, and cooperation from the patient. So, that was my last screen. I will end up my presentation. And thank you so much for your attention.
Okay, Ms. Imal, that was the last presentation.
Yes, thank you for the outstanding presentations, Ms. Ari. So, ladies and gentlemen, Ms. Ari has emphasized all aspects of cardiac MR perfusions, including its significance, patients and scanning preparations, techniques, and sequences, as well, image evaluations, and post-procedure care. Thank you so much for your presentation, Ms. Ari. And ladies and gentlemen, don't forget, if you have any questions related to this topic, you can post your questions through the Pigeonhole applications. You can access it through the chat box. And let's move on to the second presentations. It will be delivered by Ms. Laila Nur Devianti about stress perfusion imaging in nuclear medicine. So please enjoy, ladies and gentlemen.
Good evening. Thank you, Ms. Irma. First of all, I would like to thank to the committee who has given me the opportunity and the trust to be the speaker at 25th CPD Asia. At this program, I will like to present about stress perfusion imaging in nuclear medicine, actually same as myocardial perfusion imaging. Let me share my screen. As cardiovascular disease are being the world's #1 killer according to World Heart Federation, the doctor look for the best way to decrease by improve livability of the patient with CAD. Patient with CAD or coronary artery disease maybe needs some evaluation. The need of intervention with CABG, coronary stent implant in order to increase the blood perfusion to the myocard, or by pharmacological. The doctor needs good assessment to choose the right therapy for the patient with CAD, whether it is with CT coroner, MRI, or MPI. The outline for today's presentation are the definition of myocardial perfusion imaging, indication, and the contraindication. And then what instrument or material we need for the MPI study. The most step that we have to do for MPI study are the workflow on doing this. It will produce the good result and the doctor can make a good conclusion for the patient therapy. Myocardial perfusion imaging is a non-invasive imaging test that shows how well blood flows through heart muscle and can be taken with 2 steps, stress test and rest test. For stress test could be exercise or adenosine. Exercise stress test. Exercise stress test is the myocardial perfusion imaging that taken with ergocycle or treadmill. It is the preferred stress modality in patients who are able to exercise to an adequate workload. Adenosine stress test is the myocardial perfusion imaging that taken with adenosine. The indication or why we need MPI study are MPI that were useful to detect of CAD in the following patient with intermediate patient probability of CAD based on age, gender, and symptom, and patient with high risk factor for CAD. To have risk stratification of myocardial infarction, whether it is mild, moderate, or severe. Risk stratification of patient with chronic stable CAD into low risk category that can be managed medically or into a high risk category that should be considered for coronary revascularization. Risk stratification before non-cardiac surgery in patients with known CAD or those with high risk for CAD. And then to evaluate the efficacy of therapeutic intervention, anti-ischemic drug therapy or with coronary revascularization. Before bypass coronary surgery, they need MPI because the doctor want to find out whether it is useful or not if they make revascularization to myocard area with total occlusion of coronary artery. The contraindication of MPI study are patients with left main coronary artery stenosis, moderate aortic stenosis, and significant tachycardia or bradycardia. And there are some limitations on doing this study, such as exercise stress testing has a lower diagnostic value in patients who cannot achieve an adequate heart rate and blood pressure response due to a non-cardiac physical limitation with pulmonary, peripheral vascular, or musculoskeletal abnormalities or due to lack of motivation. The second one of the limitation of MPI, if it's happened, this patient should be considered for pharmacologic stress with myocardial perfusion imaging. Patient with osteoarthritis can do the exercise stress testing with ergocycle or treadmill. It's considered to have MPI with pharmacologic stress test. And patient with asthma cannot do stress test too, but they can do the stress test with adenosine. The instrument we need to do the study are, first, the most important is gamma camera. In continuous ECG monitoring, it is useful to decide the right time when have When we have to delivering the radiopharmaceutical or the tracer, we need syringe pump that can set 100 until 500 millimeter in velocity to deliver adenosine to the patient in 6 minutes. Post-processing workstation is also important to process the raw data, so we can have good result that very useful to diagnose whether it is bad perfusion or good perfusion at the myocard because of the abnormality of the coroner. The threshold that we need to do MPI study are TC99M with MyoView or MIBI. Last but not least, we need adenosine for adenosine stress test. This is the workflow. I think skip for this. Okay, this is the next slide. The workflow for the MPI study. After we prepare for the patient, instrument and material, the doctor also do the assessment to the patient. The doctor decide whether it is in stress test and rest test or just rest test. And then the stress will be do with ergocycle or adenosine. When the stress test or rest has been done, 15 until 45 minutes after injection, the scan will take. It will take approximately 20 to 30 minutes scan time. Then the radiographer process the raw data to have good data so the doctor can make a good diagnosis for the patient. There are some preparation that must be taken by the patient since 2 days before the examination, such as 2 days before the study stop beta blocker is a must. If the patient forgot to stop, it will affect on the value of maximum heart rate they have to achieve at the ergocycle stress test. And then fasting for 12 hours before the study. Last, bring the result of the previous test. The procedure of the ergocycle test is first, educate the patient about the procedure. The patient must know how to use the ergocycle and the process of cycling the ergocycle on the process of exercise. Nurse make the IV access with ABOCath and connect with heparin cap or three-way with extension. It still can be used for rest test. So after the stress test has been finished, no need for the nurse to dispatch the ABOCath. Don't forget to check the patency with NaCl 0.9% around 5 milli. Place the 12-lead ECG to the patient that connect to the monitor hemodynamic and record every 2 minutes at the process of ergocycle stress test. Place the continuous PICMO manometer, set every 2 minutes to measure, and then start the exercise test. The exercise use intensity from 0 to 100 watt. It will be raised every 2 minutes in multiple in 25 watt. Don't forget to record the ECG or hemodynamic of the patient during the exercise. It is nurse responsibility. The nurse will be inject when the nurse will be in not the nurse, I means the doctor. The doctor inject the tracer when the maximum heart rate are achieved or when we see the ST elevation, ST depression on the ECG diagram, or when the patient is unable to continue the exercise. And the dose of the tracer around 5 to 8 millicurie. Then slowly ask the patient decrease cycling the ergocycle until stop. After that, patient wait for the scan around 15 to 45 minutes at the post-injection waiting room, and don't forget to tell the patient that they have to consumption of high-fat food. Another way to have stress test is adenosine stress test. First, when we are going to do adenosine stress test, first we have to educate the patient about the procedure. The patient supine And then nurse make the EV access with a bucket and connect with heparin cap or three-way with extension. It can be used for the rest test. So after the stress test has finished, no need for the nurse to dispatch the bucket. And don't forget to check the patency with an ACL 0.9% around 5 milli. Connect the IV line to syringe pump with adenosine in it. And then place the 12 lead ECG to the patient that connect to the monitor hemodynamic and record every 2 minutes at the process of ergocycle stress test. Oh, I'm sorry, I mean the adenosine stress test. Place the continuous sphygmomanometer set every 2 minutes and then start the adenosine stress test. The dose of adenosine depends on weight of the patient. Adenosine will deliver through IV in 6 minutes and the tracer carry out at 3rd minute with the dose around 5 to 8 millicurie. Adenosine stress test finished after all of the adenosine was delivered to the patient. After that, patient wait for the scan around 15 to 45 minutes at the post-injection waiting room. And don't forget to tell the patient that they have to consumption of high-fat food. This is the slide of diagram of adenosine protocol. I have explained it at the previous slide. We see that the number 0, there is the numbers from 0 to 6. It means the adenosine delivered to the patient in 6 minutes. And at the 3rd minute, the tracer delivered to the patient through IV. This is the diagram of time to inject the tracer and time to scan. I have explained it at the previous slide and showing the time to have rest test. It is 2 hours after the tracer. Wait, I will show you. Okay, I will show you that after the scan will take there is 30 minutes and until 60 minutes after rest injection, the patient waiting at the room of post injection and then take the scan after 30 minutes and the scan approximately 20 minutes. After we process the raw data using software, the image view, we will have short axis view, vertical long axis view, and horizontal long axis. We will have slices for every view. At this slide, we see the bright color of myocard. It means the perfusion to the myocard is very good. So when the color not bright, even dark or black, it means there is a defect at myocard at certain segment. So we must know the rule of segmentation of myocard. At this slide, we can see clearly. At the left side, we see the myocard in bright color in every view. And the right color side, we see the myocard with a lot of defect. Some segment in dark color and some segment loss of color. Okay, according to this myocardial segment, we can see at which area that have a defect and which coronary with abnormalities perfusion to myocard. When the defect at the yellow color, it means there is a problem of perfusion at left anterior descending artery. And when the defect at the red color, it means there is a problem of perfusion of right coronary artery. When the defect at the yellow color, it means there is a problem of perfusion of left circumflex artery. With the software at Nuclear Medicine to process raw data, we also have the heart pump visualization. It is very useful to see which is the normal heart pump and which is in abnormal heart pump, or at which segment of myocard have an abnormal on pumping of the blood. Okay, now we have to the conclusion. First, myocardial perfusion imaging is a non-invasive imaging test that shows how well blood flows through heart muscle. Second, myocard perfusion imaging can diagnose coronary artery disease. And the last, myocard perfusion imaging result the viability of myocard, and it's useful for decide best therapy to the patient with coronary artery disease to improve their ability of life. Okay, thank you. That's my share. Maybe if you have some question, you can type your question at chat column. Okay, thank you. And time I will give to Miss Irma, and I will stop share screen.
Okay, thank you for your great presentation, Ms. Devi. And ladies and gentlemen, Ms. Devi has emphasized on considerations when performing myocardial perfusion in nuclear medicines, especially its significance, instrumentations that we use, the preparation, imaging technique, and image evaluations. Thank you for the outstanding presentation, Ms. Devi. And ladies and gentlemen, if you have any questions related to the presentations, you can post your questions again through the Pigeonhole applications. You can access it through the chat box. Okay. And now for the last presentations, we have presentations from Dr. Mira Yuniarti. We'll be talking about the image assessment of cardiac MR perfusions. So ladies and gentlemen, please enjoy.
Hello, good evening, everyone. Thank you for your introduction. First of all, I want to say thank you to the committee and to all the participants on this meeting. I am honored to be given this chance to share my experience in cardiac MRI. Let me share my screen. Okay, the title of my presentation is Cardiac MRI Assessment of Myocardial Perfusion. Introduction. As we know, coronary artery disease is the most common cause of mortality and morbidity around the globe. Assessment of myocardial perfusion to diagnose ischemia is commonly performed in symptomatic patients prior to referral for cardiac catheterization. CMR is increasingly used to evaluate rest and stress perfusion and to identify myocardial ischemia and infarct with a high degree of accuracy. Stress CMR is non-invasive one-stop assessment of myocardial ischemia, myocardial viability, and cardiac function. Limitation in myocardial perfusion analysis by CMR are lack of availability of CMR imaging expertise in many centers, patient-related such as obesity, claustrophobia, forgetting, motion artifacts, contraindication to use of vasodilator agents, and gadolinium contrast agents. Myocardial perfusion on resting coronary blood flow increases with exercise or other stress. However, significant stenosis coronary blood flow cannot increase with stress and an inducible perfusion defect apparent in the relevant coronary artery territory. Perfusion CMR can identify this perfusion defect and correlation with myocardial scintigraphy. CMR allows improved resolution with no ionizing radiation. How to do stress perfusion? We choose adenosine because adenosine is the most commonly used vasodilator stress agent in clinical practice. Patient must avoid caffeine-containing products such as coffee, tea, and chocolate for 24 hours beforehand. The first one, an infusion of intravenous adenosine with dose 140 microgram per kg per minute for 3 minutes. After that, we give a bolus of intravenous gadolinium, dose 0.1 millimole per kg at a rate of 7 milliliter per second, followed by 15 milliliter of normal saline at the same rate. Ventricular short axis lysis, including basal, up, mid, and apex, offer the first cardiac cycles of this first pass perfusion. Image acquisition is over 60 seconds and patients are instructed to breathe gently when needed. Rest perfusion. Resting perfusion is delayed for 10 until 20 minutes after stress perfusion. This time is to reduce gadolinium levels in myocardium. We use ECG-gated T1 weighted images are obtained using gradient echo, hybrid gradient echo planar, or steady-state free precision imaging. Perform using the same dose and rates of gadolinium and saline as those for stress but without the adenosine. Consider abnormal if upon gadolinium and sun administration, a low signal of T1 weighted image is detected in a myocardial segment, which persists for a period of at least 5 heartbeats. This is vasodilator stress cardiac MRI protocol. The first 10 minutes, we do Scott imaging, Sina imaging except short axis SSFP 1 stack, and then continue with adenosine infusion for 3 minutes, continues with IV gadolinium contrast injection, then we do dynamic stress perfusion. Before we do dynamic rest perfusion, we can make a short axis Sina stack imaging, and after 10 minutes, we inject gadolinium contrast and do the rest perfusion. And we have time 5 minutes before we doing LG imaging. So in this additional needed imaging like RVOT, or maybe flow imaging we can do here. This is CMR sequence of myocardial perfusion. The first one, contrast enters the right ventricle and then left ventricle and then perfuse all the myocardium. This is first pass perfusion signal intensity. We can see the normal myocardium is perfuse all the myocardium, but in ischemic myocardium is lower perfusion and decrease of T1 signal if we compare with the normal myocardium. This case is example for three vessel disease. We can see the perfusion defect almost all the LV myocardium except on the anteroseptal segment. And after rest perfusion, the myocardium is back to normal in the same slice. This patient has perfusion defect in the anteroseptal and anterior segment of basal LV, and then on rest perfusion, the myocardium back to normal perfuse. On LGE, we can see no net gadolinium enhancement, and on coronary angiography, we can see occlusion in the mid LED. This is a patient with microvascular obstruction. We can see the hypoperfusion defect in almost all of the left ventricular myocardium, and back to normal perfusion on rest perfusion, and no late gadolinium enhancement. But we can see in the coronary angiography, no obstruction or stenosis in the coronary artery. So that's mean is because of the microvascular obstruction. On this protocol, we also do CINA and late gadolinium enhancement or viability imaging. On CINA, we can assess the left and right ventricular systolic function, and on LGE is the best technique presently available for locating and sizing myocardial infarct. The ideal CMR technique for LGE with the use of inversion recovery or TI to null normal myocardium. This is LGE mid-ventricular short axis view on the appearance of the myocardium when the inversion time is set. A is too short, B is too long, and C is correctly. The report of perfusion CMR include: one is anatomical description of the perfusion defects, follow the 17-segment model. Two is correlation of this defect with the pattern of percentage of LGE. Three, description of viability. Four, quantification of ventricular function. On late gadolinium enhancement, we have to percentage the transmurality of the myocardial infarct. We categorize normal, and then 1 until 25%, and then 25 until 50%, then 51 until 70%, and more than 75%. So if the myocardial infarct is less than 50%, that means the myocardium is still viable. But if more than 75%, the myocardium is non-viable. This is the case. We can see before stent, there is abnormal wall motion on the septal, anteroseptal segment of the LP. We can see the hypokinetic of the myocardium and no enhancement on LGE. After stent, the myocardium can normokinetic. And the second patient, we can see before stent, there is abnormal wall motion in the basal anteroseptal. On the LGE, we can see transmural enhancement more than 75%. And after stent, the myocardium still hypokinetic. So that means if we see the stenosis or the scar tissue is less normal or no myocardial infarct or less than 50% is candidate for revascularization. It could be PCI or CABG. Don't forget about dark rim artifacts on myocardial perfusion. Normally lasts for a few heartbeats and vary temporarily, and normally we can see dark rim artifact when the contrast move from the right ventricle to the left ventricle. Normally lasts for a few heartbeats and vary temporarily as the contrast bolus passes through the left ventricle blood pool, while a real perfusion defect tends to be visible for a longer duration of the imaging. As a conclusion, CMR is emerging as a highly sensitive and specific test for myocardial ischemia and infarction. And stress CMR is non-invasive one-stop assessment of myocardial ischemia, myocardial viability, and cardiac function. Thank you for your attention. I turn back the time to the moderator. Thank you.
Well, thank you, Dr. Mira, for your great presentation. So, ladies and gentlemen, Dr. Mira has emphasized on the basic concept of stress and rest imaging, of perfusion imaging for cardiac, and she also emphasized on image assessment and the content of cardiac MR perfusion report. So, thank you once again for Dr. Mira for your presentations. So, ladies and gentlemen, that's the end of the presentation session. Let's move on to the next session, which is the Q&A session. Once again, for all participants at home, please drop your questions to our speakers through the chat box or Pigeonhole applications. And for the Q&A sessions, please let me call again our dear presidents and all panelists to join us in this session and to help me moderate with these sessions. So for all the panelists, you can open your mic, and if you have any some points to add up or questions to the speakers, so please let the speakers know. So for the presidents and panelists, do you have any questions?
A very good afternoon. Today, all the three speakers did very well. All the topics covered so nicely. Congratulations to all. So
Thank you, Mr.
there is no
Sal.
questions. It's a really a nice, good talk. There's a lot of informations.
Thank you, Mr. Selvakumar from India. So for other panelists, do you have any points to add up or any questions before we check on the Pigeonhole app? Maybe any questions from other Zoom meeting room from other countries? Okay, if
Yeah,
there's no
please
question,
open your speaker.
yes, Miss Chailai Kwan from Malaysia.
Okay, I'm actually not really, familiar with MR perfusions for cardiac, but I have seen a lot of nuclear medicine perfusions. So I just want to ask whoever out of the three speakers, what decide, patient condition, what will decide to choose which modality? Because all are cardiac patients. So anybody can actually just give me some idea when you decide the patient should go for nuclear medicine or MRI or the other perfusions. Thank you.
Okay, thank you, Miss Chailai Kwan from Malaysia. Maybe Dr. Mira or Ibu Devi or Ibu Ari, Miss Ari, can answer the questions. So when the patient should go to the CT or MR or nuclear medicine, so how do we choose the modality?
Okay, thank you for the question. I'll try to answer the question from Miss Chan Lai Kwan. Yeah, as we know, for case is like a CAD, if the patient has complaint with the unstable chest pain like angina pectoris, yeah, we need to do a CMR, myocardial perfusion to make sure there is inducible ischemic or not, because this very important to decide what the treatment for the patient. It needs revascularization or not. So we have to make sure to do myocardial perfusion. It can be CMR or with radionuclear and other stress tests like treadmill tests and others. Thank you.
Thank you, Dr. Mira. So how about the answer, Miss Chan Lai Kwan? So Dr. Mira, does it mean that so whether it's CT or MR or nuclear medicine, so all of the modalities has the same output? All are important,
Yes.
or we can just choose one modality?
Yeah, we can choose a CT or MR perfusion.
Oh,
Yeah.
CT or MR. Okay. So Ms. Chan Lai Kwan, do you want to add up?
Thank you. I guess so because the availability of the modality is important. Even though, because like, I think not everywhere you can get nuclear medicine. Even though I think it's quite good for cardiac imaging because it actually show you the viability of the muscle of the heart. But I think not every hospital have that modality. So I think CT and MRI is more easily available.
Yes. Thank you, Mr. Chan Lai Kwan. So it depends again on the accessibility and the availability of the modalities, right? Okay. Thank you, Mr. Chan Lai Kwan. Do you have any more questions from the panelists? Or
Hello,
from the president?
I have question for, yeah. First of all, yes, thank you. First of all, allow me to represent the president of FRA, Mr. Thái Văn Lộc, to send a pledge greeting to the CES 25 CPD hosted by Indonesia, and hopefully is the conference will success. And second, I have a question. It's not totally a question. It's about a discussion to the second and third speaker about depend on the clinic or center of your country, but you have many the technique, imagine technique in the cardiovascular disease, especially myocardial ischemia. Like MRI, CTA, or coronary intervention, or SPECT or PET-CT. So which technique do you like it the best for patient in now? Yeah. So yeah, two the second speaker or third speaker can answer. Thank you.
Okay, thank you, Mr. Lu Tri Dong from Vietnam. So the question is directed to the second and third speaker, Ms. Devi and Dr. Mira. Would you like to answer the question?
Sorry, Ms. Irma, can you repeat the question? Maybe I lost for the first statement.
Okay, Mr. Lu Tri Dong, can you repeat it once again, the question?
Yes, yes. My discussion or my question is depend on your center, but which one do you think about the best for patient, especially myocardial ischemia patient? MRI, CTA, cardio MR, or CTA, or coronary intervention, or SPECT or PET-CT. So which one do you want to think about the best? It's the best. Can you explain?
So maybe Ms. Devi or Dr.
Yes.
Mira. So which modality do you think the best to show or diagnose the ischemic case?
Yes.
Yeah, is it CT, MR, or other modality?
Yes.
Yes.
Okay, I'll try to answer the question. First of all, we have to know the clinics of the patient, and then and absolutely the one who has to choose which one the best modality to this patient with ischemia is the doctor, not me. Absolutely, but each of that modality has sensitivity. And it depends of the doctor which one do they want to choose to make to know about the ischemia for the patient. But for me, absolutely, I will choose MBI.
Yes,
Thank you.
yes. Yeah, thank you. Yeah, I think as I know, just depend on the doctor when which one the doctor will choose to do the best for patient. But yeah, I want to debate you. What would you think? Yeah, what you think about for the technologist from a technologist? Yeah.
Yeah. Maybe Dr. Mira, you have a different opinion or want to add some points maybe? Which modality will be best for the patient?
Yeah, I just want to add the information, Mr. Lu, for case of myocardial ischemia in our country, we prefer CMR because with CMR, we not only see the myocardial perfusion, but we can also see the function. We can measure the function of the right and left ventricle, and also assessment for viability of the myocard. There is the myocard is still viable or not. So MRI is still the best choice for the ischemia case. Thank you.
Yes, thank you. I think you too. I also think with you. The cardiac MRI now it's this time it's the best for the patient with myocardial ischemia. Yes, because it's a yeah, many reason, but I also think that MRI is the best. Yeah, thank you very much.
Thank you.
Thank you, Mr. Lu, Tridang, and Dr. Mira and Ms. Devi for the discussion. Yeah. So Dr. Mira goes to MR. Okay. Okay, so any more questions from the panelists or the presidents? If no, Pichi Luna posted a question from Philippines, maybe from the members or from Pichi itself. So she asks how to limit the potential artifacts and how to correct them for Ibu Devi, maybe in nuclear medicine, or Ibu Ari, Miss Ari. Is there any potential artifacts that may rise from nuclear medicine or magnetic resonance imaging, and how to correct them? Maybe Miss Ari, would you like to answer?
Okay. I'd like to try to answer the question. The artifact that often come up at the CMR is a wraparound artifact. There is several ways to reduce wrap artifact. The first is we can increase the field of view. And then the second one is we can add pulsar encoding, or in other machine we call pulsar oversampling or fold over suppression, or in our machine is we call it no pulsar wrap. And the third one, we can swap pulsar and frequency direction. And for the last, maybe if the patient is too big, we can positioning the patient hand over the head if it is possible. I think that's my answer.
Okay, thank you, Miss Ari. Thank you for the answer. So Miss Ari has answered that we may play with the FOV and encoding phase and phase directions. And if the patient is big, we can put their arms above the patients. Yeah. Okay. Any more points to add up, dear presidents and panelists? Okay. Bliputu, can you show us the pigeonhole?
Yes, sure.
So we can see the questions that has been asked from the participants at home.
Yes.
Oh, we have a lot of questions.
Yeah.
Okay, the first one with 3-fold, maybe it is directed to Miss Ari. From Dede. Yeah. Can the patients with heart rhythm abnormalities have MPI and MRI examinations? Miss Ari, would you like to answer that?
Okay, I try to answer the question. Okay. For patient with arrhythmia, we can do several techniques. First of all, we have to know what kind of degree of arrhythmia the patient has. One of the technique that we can do is we can do heart rate or rhythm control before scanning by giving beta blocker or other anti-arrhythmia medication. And the second one, we can use arrhythmia rejection by increase the breath hold time. The other way to use the prospective triggering, it used to reduce the CNR. And the last, we can use real-time imaging by reducing temporal and spatial resolution as well as SNR. Okay, that will be my answer. Thank you, Ms. Irma.
Okay, thank you, Ms. Ari. So, Mr. Dede, so Ms. Ari has answered that we can control the rhythm by giving the patients beta blocker or anti-arrhythmia medications. We can also increase the breath hold time and reducing the resolution, if that's right. Okay. So there are several ways that we can do. So it means that the patients with heart rhythm abnormalities still can have the examination. Thank you for your question, Mr. Dede. And the second question, Bli Putu, you can zoom one of them.
Which one?
Okay, maybe, yeah, for Dr. Mira, that's okay.
Okay.
Okay, for Dr. Mila, the question is, which are of those indications in cardiac MR we should do the early gadolinium enhancement sequences? Should we do to all indications or just for a specific indication?
Okay, thank you for the question. Early gadolinium enhancement is not routine for ischemic case, but early gadolinium enhancement is the first purpose is to see there is a thrombus or not. So we have to do early gadolinium enhancement. But if the doctor don't want to miss the thrombus, like the small thrombus, better you do AGE in every examination of CMR. Thank you.
Okay, thank you, Dr. Mira. So it's optional, okay, if we want to see the thrombus especially, right? Okay, next, maybe one question maybe for, yeah, Miss Leila. So the question is directed for Miss Laila or Ibu Devi. Are there any other radiopharmaceutical that can be used for MPI procedure? Ibu Devi?
Okay, thank you. If you don't have Mioview or tetraphosphamine, you can change that with Cetamib. Usually we use that if we can get Mioview.
Okay, thank you for the questions, Ibu Devi. So there are other options for the pharmaceutical. Okay. Okay, maybe that one from Koirul Huda, because all of the speakers are talking about caffeine. Why do we need to avoid caffeine? Yes, for Ibu Leila or Dr. Mira, maybe why before the examinations of nuclear medicines, the patient is not allowed to drink anything that contain caffeine? For Ibu Devi or Dr. Mira?
Okay, I'll try to answer. Caffeine have the same effect with adenosine. So when we do adenosine stress test and the patient has consumed contain caffeine, so the heart rate will not raise as usually. So the adenosine stress test will fail. We cannot do stress test when the patient consume caffeine. That's all. Thank you.
Okay, thank you, Ibu Devi. So it may affect the examination. Yeah, it will fail the stress test. Yeah. Okay. Any more questions? Maybe Bli or artifacts from Mr. Ludi already answered by Miss Ari.
Bu Irma,
Yes,
Gatot speaking.
yes,
I think
Pak Gatot.
we need to consider the question number 3 in above. Yeah, I think this
Number
is
3.
important.
Okay.
Dr. Mira, I think you need to share the idea for the breastfeeding moms, not only for the CMR or MBI, maybe for the iogenic contrast media for the breast mom father, how long they can feeding the babies again after the exam done. Not only for the CMR and MBI, but also the ionic contrast media. Please. Thank you.
Thank you, Mr. Gatot. Good spot, yeah. So for breastfeeding mothers, how long they can breastfeed again after they got contrast injection? Dr. Mira, would you like to answer?
Yeah, for breastfeeding mother, the contrast media will be washed out after 24 hours after examination. So after that, they can give the breastfeeding. So only 24 hours.
So that is including the ionic contrast media, doctor, for CT or maybe the IVP. Oh, okay, sure.
Yes, same part.
Thank you, doctor.
Thank you, Dr. Mira. Thank you, Pak Gatot. Maybe one more question, please, from caffeine, artifacts, and caffeine again. Beside adolescence. Oh, maybe the questions from Kartik K. Dibli. How to do cardiac MR for low heart rate patients like 50 or 60 BPM? For Dr. Mira or maybe it's for Ibu Ari, Mbak Ari? If the patient has low heart rate like 50 or 60 BPM, how do we do it for the cardiac MR?
Yeah,
Oh, I see. Sorry.
Oh, yeah, it's okay.
it's okay.
Yeah, maybe Dr. Mila first, maybe.
Yeah, this heart rate is the best candidate for cardiac MRI. Yeah? If they have like 60 and under than 60. So it's I think not important issue for this. Maybe Miss Ari can add information.
Okay, Miss Ari, would you like to add some points?
I'd like to try to answer. In harapan kita, based on my experience for this kind of patient, we do the CMR with rest perfusion because for the SINA or for the other sequences it's okay, but for the using adenosine, the doctor usually choose not to use adenosine, but only doing the rest perfusion. I think it's my answer. Thank you.
Okay, Miss Ari, so then the examination will go straight away to rest perfusion if they have low heart rate. Yeah. Okay, any more questions? Or maybe the last questions, please. For Miss Ari and Miss Devi, what should we do in emergency, maybe? Yeah? For example, suddenly the patients cannot breathe or something else during the examination. So I think it's related to emergency response. Would you like to answer, Miss Ari or Miss Devi, based on your experience?
Yeah, I'll try to answer first, maybe before my
Yes.
friends answer for the second step. Usually when we are in emergency condition, I mean code blue at my hospital, we are a team doing this examination. There is a doctor, nurse, radiographer, and we will try to look the best way how to to know what really happened to the patient. If the doctor, maybe sometimes the doctor doing CPR, or maybe they have to move the patient to emergency room.
Okay, thank you, Miss Devi, Bu Devi. So code blue immediately and perform the basic life supports and work in a team, right, Miss Devi? Okay, if that's the point. And Miss Ari, would you like to add some points
No,
based on your
I think it's
experience?
enough. Mr.
Oh,
Devi already, Miss Devi already answered that. Thank you, Mr.
Okay.
Devi.
Thank you, Miss Ari. So any more questions from the panelists, maybe? Would you like to add some questions, or is there any questions from other countries? You can forward it to our chat box for the team support from other countries. No? Okay. Well, I think if there are no more questions from the panelists or from the participants, I think this marks the end of our Q&A sessions. Thank you so much again for your participations for the participants. And thank you again for all of the speakers, especially Dr. Mira, because we know that you are sick today, but you are committed to present here today. Thank you so much for all the speakers and delegates, the panelists, and the participants for your active participations during the Q&A session. Okay, ladies and gentlemen, this is the end of our scientific sessions. And for the next sessions, I will head back to our MC, Pichi Luna, for announcement of the next CPD Asia and for the closing ceremony. Thank you so much. Pichi?
Yes, thank you so much, Ms. Putu Irma Wulandari, our program session moderator. We would like also to say thank you very much to all our presidents and the panelists. The PARI, Perhimpunan Radiographer Indonesia, has just provided us with 3 great speakers who have just shared to us very interesting and important discussions. From CPD Asia, I would like to say thank you, Ari Dwi Jayanti, Leila Nur Divyati, and of course to Dr. Mira Yunyarti. We have learned so much from your very interesting discussions. Now, in the interest of time, we have to cut from here to give way for the closing session. I know we are all excited to know about the next exciting online CPD Asia schedule, and I am more happy to announce that the Philippine Association of Radiologic Technologists Incorporated will host the 26th CPD Asia, and that's happening on June 25, 2023. And please keep updated as we shall be posting more details soon. So in closing, we would like to say big congratulations to Perhimpunan Radiographer Indonesia, or Indonesian Society of Radiographers, or PARI, to President Dr. Giek Subianto, to all the PARI officers, the organizing committees of the 25th CPD Asia. We give thanks to the support also of our many sponsors, and also to Vietnam, VT Healthcare. We are grateful to our great speakers, and most of all, we are sincerely grateful to all our member societies presidents, to our very hardworking CPD Asia IT team, and to all the registered participants who have made this online CPD Asia program a success. We would like to see you again in the next Asia CPD. Again, I am Pichi Luna, and I say thank you, everyone. Have a great day.
Thank you.
Congratulations, Pichi, for your next CPD program. We are going to conduct. All the best. Thank you, Pari, for making a good program today on MR.
Thank you, sir. See you.
Thank you,
you.
Mr.
See you.
Kumar. Thank you,
Thank
Pichi.
you, Bu
Thank you,
Hari.
everyone.
Hari, makasih. Mbak Devi, Mbak Laila.
Terima kasih, Mbak Ari, Ibu Devi, Dr. Mira. Sehat-sehat. Sembuh, Dok.
Makasih, Dr. Mira.
Tas boleh, Bu Dokter.
Happy Sunday to all.
Ya, terima kasih, Dok.
Thank you. See you
Thank you, Presiden
soon.
semua.
Bye.
Stay safe, Pichi, and everyone's from Philippines.
Yes, yes, thank you.
Bye-bye.
Bye-bye, ma'am.
Thank you,
Madam
Mr.
Chalak,
Chalak.
Thank you.
Thank you, Jessica.
Chairman
you.
Karanang, thank you. Madam Chan Laikwan, thank you.
Thank you, Debbie.
Thank you, Bang Ari.
Thank you, Pichi. Thank you, everybody. It's so nice. At least we see online once a month.
Yeah.
Thank you, Madam
Yes,
Chan.
correct, madam.
See you
Yes,
in Malaysia, Madam
Oh,
Chan
See you
Laikwan.
in Malaysia.
Yeah, we see everybody, even we are in separate country. So this is a good platform. I actually try not to miss anyone. Have a good Sunday. Bye.
Thank you, Mbak Putu.
Terima kasih.
Bapak Ibu, pre-test dan post-test itu di post-test sudah ada di kolom chat. Terus kemudian untuk penutupan, Miss Irma, I would like to play us the Hymnal of Pari as a closing.
Thank you, Bli Putu. Pichi, thank you once again. See you next month.
yes, thank you again. Thank you, everyone. Thank you, everyone in Indonesia.
You have many fans in Indonesia, Pichi.
Oh, really? Thank you so much.
Yeah.
Po. Wow, thank you so much. I wish I could go back again in Indonesia.
Yeah,
Yeah.
thank you.
Permission
Maybe
to
you
leave
can.
the Zoom. Oh,
Okay, see you.
Okay, see
yeah,
you.
permission to leave the Zoom. Thank you.
Thank you, Pichi. Selamat sore, Pak Rustanto, Pak Arsyan.
Selamat sore, Mbak.
Ya, selamat sore, selamat berdinas.
Ya. Wow. Sangat-sangat exciting ya, Mbak ya. I'm so very exciting to
Aduh, kok baru keluar Inggrisnya tadi? Harusnya keluarin Inggrisnya. Just now you're exciting.
Yeah.
You should spill
Pak
out your
Madepurwo
excitement.
ini lagi ini bergelantungan, Pak Madepurwo ini ke bawah ini, Pak.
Where is Pak Madepurwo? Where?
Oh, menghilang Pak Madepurwo.
I don't see Pak Madepurwo. Oh iya.
Tadi Pak Madepurwo bergelantungan di
Ya
atas.
tadi Bapak Ibu mohon maaf kelok meetingnya karena banyak ininya Miss Irma banyak kita ngaktifin co-host, jadi nggak tahu siapa co-host yang ngeklikin lock meeting, so tadi meeting sempat kelok, cuman kemudian dibuka. Last tadi ada 323 ya, saya lihat partisipansnya. Kemudian di Zoom yang lagi satu tadi ada sekitar 16-an. Jadi kita aktifkan 2 Zoom yang link, Zoom 1 dan Zoom 2 di sebelah.
Siap. Terima kasih ya, Bli. Terima kasih Bapak Ibu semuanya atas partisipasinya. Tuh Mbak Yulia Devika, terima kasih sudah mantengin dari tadi. Ya, sama-sama Mbak.
orang itu yang
Pak Arisa Songko, terima kasih.
rumah papan itu.
Salam kenal.
Salam kenal, Mbak Irma.
Ya.
Oke, saya izin untuk memainkan himne Pari sebagai penutup, dan begitu selesai himne Pari maka Zoom akan saya end meeting for all. Bapak Ibu silakan mengisi post-test, dan sebagai syarat ada pre-test, post-test, kemudian nilai 70, waktu join Zoom nanti semuanya akan dikalkulasi. Begitu yang memenuhi syarat akan memperoleh sertifikat 1 SKP. Begitu informasinya. Bu Irma, without further ado, I just following your words. I will play the hymn Pari. And then after hymn Pari end, I will end meeting for all. Oke, izin end meeting for all. Sampai jumpa lagi. Miss Irma, see you tomorrow.
See you tomorrow, Bli.
Oke, sampai gangan dulu nah, cara gas dulu nah.
Terima kasih Bapak Ibu.
Ayo,
Pak Rustanto sudah boleh end meeting sekarang. Serius sekali Pak.
Pak D aja ya. Pak D, wes nih. Aja ngopi weh. Ya, izin end meeting for all ya. Baik semuanya. Yuk.